Welcome to the North Carolina College of Resuscitation. I'm Jamie Jollis. I'm a cardiologist at Duke University. Along with thousands of colleagues in North Carolina, we're all working to improve emergency cardiac care.
I'm Chris Granger. I'm a cardiologist at Duke University, and I'd like to welcome you to this series of presentations on a very important project for the state of North Carolina. That is the Heart Rescue Project, or RACE CARS. And this is the project to improve survival for patients with cardiac arrest by 50% over 5 years in the state of North Carolina. And it has a series of proven interventions that we need your help with, that include interventions in the community to increase rates of bystander CPR and to educate the public to activate the EMS system when a cardiac arrest is identified. It involves the best practices by emergency medical services, including rapid application of defibrillation and best care in transportation and destination to the best centers able to care for patients with cardiac arrest, and then hospital measures that include primary PCI when that's indicated, therapeutic hypothermia, and best care for patients with cardiac arrest during their hospital phase, including consideration for implantable defibrillators. And by doing all of these things, we believe that we can be very successful in improving survival for patients with cardiac arrest.
North Carolina EMS State Protocols Cardiac Arrest Protocol Update. Our objectives today, we're going to review the 2012 North Carolina Chapter of Emergency Physicians EMS Cardiac Protocols, specifically looking at cardiac arrest, PEA or pulseless electrical activity, asystole, VFib, VTAC or ventricular fibrillation, ventricular tachycardia. We'll also introduce the hypothermia protocol and an update to the post-resuscitation cardiac protocol. I'd like to emphasize that all highlights and updates are consistent with the 2010 AHA recommendations. A disclaimer of note, as of this filming, the 2012 NCEP EMS protocols are currently in public comment. The final draft version has been approved by the NCEP Board of Directors, but the final version will change based upon public comment. Team-focused or pit crew approach to CPR. This is a recommended concept, not mandated and optional for agencies to adopt and change as they see fit based on their circumstances locally. The idea with team-focused CPR that responders are assigned a task, either based on their arrival on scene or perhaps where they sit that particular day in an engine company or a rescue agency. So this works well with both volunteer and career agencies. There's a focus on compression-only CPR, at least initially, and the focus is on high-quality, continuous, uninterrupted compressions and focus on early defibrillation and AED use. There's also a focus on the insertion of a blind insertion airway device, such as a combi tube or a King airway, in lieu of interrupting compressions to place an endotracheal tube. There's a focus on the prevention of hyperventilation and hyperoxygenation, with the key of maintaining oxygen saturations at 94% or greater. As you can see, this is the team-focused CPR protocol. One thing you will note is the protocols for 2012 will be 2 pages. Page 1 is the typical protocol that we're accustomed to. Page 2 has a purple shaded section that allows the local medical director to add caveats to that protocol and how they want those protocols interpreted. And then the pearl section appears either at the bottom of page 1 or page 2. And stepping through the protocol, you can see that as responders arrive on scene or with a career agencies, they are assigned certain duty tasks. Basically, the first person is responsible for hands-only, compression-only CPR, followed by the responder 2 utilizing an AED or changing with a compressor or placing a blind insertion airway device. The third arriving team member establishes the team leader, and that's an important concept for team-focused CPR. Every team has to have a leader. The team leader hierarchy can be decided at the local level, but here the example that's listed with the volunteer agencies or non-EMS agencies, typically that may be a fire engine captain or a rescue captain, then an EMT basic, followed by a first responder. If ALS is available, then the advanced life support crew will take on the role of team leader. Even though there is an established team leader for this protocol, one should remember that every team member is responsible for high-quality, uninterrupted, and continuous compressions of the proper depth and the proper rate. Adult CPR protocol. Going forward, you'll see many of the same suggestions that are listed over and over for these protocols. Emphasize compressions first, high quality, continuous, uninterrupted compressions. Focus on early defibrillation or use of the AED. Caveat to change compressors every 2 minutes to limit rescuer fatigue and decrease the effectiveness of our compressions. And then limit those interruptions to less than 10 seconds. There's also an emphasis on the adult CPR protocol and team-focused CPR protocols to inquire early on about a DNR of most form. There's also caveats concerning maternal arrest with the manual left uterine displacement procedure where the mother is placed supine and then the uterus is displaced to the left. There's also an emphasis on the utilization of intraosseous devices where difficult IV access may be evident. This is a copy of the adult CPR protocol. Notice there's page 1 and page 2. Pearls appear at the bottom of page 2. The large purple section is for the local medical director to make changes. This hasn't changed a great deal from the 2009 version, with the exception of the updates to the 2010 guidelines. You'll notice that the Pearl section that appears at either the bottom of page 1 or page 2, depending on if the protocol is 1 or 2 pages, lists several caveats of importance germane to that particular protocol. Adult PEA and asystole. This year the PEA and asystole protocols have been combined, congruent with AHA recommendations. Atropine has been removed from the protocol for routine use. You'll also notice that there are protocols that are listed to the side to consider, such as beta blocker, calcium channel blocker overdose, other toxicological considerations, and also a renal dialysis protocol caveat for those folks who may be at risk of hyperkalemia. This protocol also emphasizes compressions first, high quality, continuous and uninterrupted compressions. The compressor change every 2 minutes and limit compressor interruptions to less than 10 seconds. Here you can see a copy of the protocol. You'll also notice that some sections are shaded in purple, such as epinephrine or IV administration dosages. The local medical director is able to change those medication dosages or IV dosages congruent with local standards and availability. Adult ventricular fibrillation and ventricular tachycardia protocols. Again, the emphasis is on compressions first with high quality, continuous, uninterrupted compressions, changing that compressor every 2 minutes and limiting those compression interruptions to less than 10 seconds. In addition, IV medication drips have been added to the protocol, i.e. if you're using amiodarone, an amiodarone drip has now been added to the protocol. There's also a caveat for renal dialysis consideration where hyperkalemia may be at play. There's also a caveat added for torsade de pointes where magnesium sulfate may be utilized. And you can see the protocol as it exists, page 1 and page 2. You'll notice that multiple antiarrhythmics exist, many of which may not be carried by the local agency. Those medications can be removed and the antiarrhythmics that your agency carries can be placed. Induced hypothermia. This is an optional protocol. It's been added based on available evidence of improved outcomes in selected patient populations. The caveat for this protocol is it must be used in conjunction with your region. We can't initiate induced hypothermia if our receiving hospitals will not continue that therapy. And here is a copy of the induced hypothermia protocol. As you can see, the criteria for utilization of this protocol, we have included all comers. That is, folks who have suffered a cardiac arrest, but it is not specific to ventricular fibrillation or ventricular tachycardia. It would also include folks who have PEA or asystole as a presenting rhythm. And the methods of cooling are basically ice packs and or ice-cold fluids. Post-resuscitation protocol. Certain aspects of this protocol now follow current AHA recommendations of maintaining oxygen saturations at 94% or greater, but to avoid hyperventilation and hyperoxygenation, which we know worsen outcomes. The main keys are to optimize cardiopulmonary function and optimize vital organ perfusion. There's also caveats related to STEMI. If a STEMI is recognized, that STEMI protocol should then be employed. Temperature control, and also transporting to appropriate hospital with comprehensive post-cardiac arrest treatment. This is a copy of the post-resuscitation protocol. You can see as we go down the protocol that there are several decision boxes that cause you to go in directions but also allow you to come back into the protocol. In summary, the Advanced Cardiac Life Support and Pediatric Advanced Life Support protocols have been updated to the 2010 AHA recommendations with caveats of aggressive cardiac arrest care and aggressive post-resuscitation care.